Good afternoon, everybody. Thank you. There is something wonderful even at the end of this conference. Isn't it wonderful? It's not just at the beginning, but also the end. There's going to be a wonderful, wonderful session. Hello, everybody. My name is Louise Bauer, and I'm here in my role as immediate past president of the World Obesity Federation, because this is a World Obesity Federation session looking at the bigger picture: lifestyle modifications, pharmacotherapy and surgery. And my co-chair is Ricardo Cohen, who's the new president of IFSO as of today. However, because he's actually giving a talk, I'll be moderating initially. So thank you. We've got something fantastic even at the very end. We've got 4 speakers. We're going to be covering a range of different topics. If there's time at the end of each talk, we can actually ask questions, and then we'll have a panel discussion at the end. Now, our very first speaker is Gary Whittet, Professor Gary Whittet from Adelaide Medical School, who is the Mortlock Professor of Medicine at the University of Adelaide, a senior consultant endocrinologist at Royal Adelaide Hospital, and director of the Freemasons Foundation Centre for Men's Health, and also editor-in-chief of Obesity Research and Clinical Practice. Has an enormous long-standing expertise in many aspects of obesity and men's health, and today he is going to be talking about the role of lifestyle interventions in the era of modern pharmacotherapy. Thank you, Gary.
Thank you very much for the kind introduction, Louise, and thank you to World Obesity for the invitation to be part of this symposium. And I realise that I'm one of the 3 people standing between you and an after-conference drink. So I've called this Lifestyle Interventions First, Foremost and Forever, because I thought I would set the tone for what I really want to say, and that is lifestyle interventions are first, foremost and forever. First point I want to make is that it's extremely common. It's common to find that there are micronutrient deficiencies in people living with obesity. And this comes not just from studies where people have presented for bariatric surgery, but where people have come for obesity treatment for a range of therapeutic modalities. This has been attributed to the fact that while the diets are energy dense, they're also micronutrient poor, that there are metabolic changes related to obesity, including those secondary to inflammation in the presence of gut flora that affect micronutrient absorption and intermediary metabolism, that calorie restriction without optimizing dietary micronutrient content will exacerbate pre-existing deficiencies. And 1/3 of people, older people with obesity, have poor overall nutritional status, and this is a cause of decreased functional capacity, impairment of balance, gait, failure, falls, and depressed mood. Here is a little bit of data, more than 10 years out of date. Well, not out of date, it's still contemporary data, I think, because more recent studies are very similar. But you can see that in people with obesity without diabetes and in people with obesity with diabetes, these are the sort of prevalence of B vitamins, folic acid. You would rarely see deficiency in Australia because of supplementation. Vitamin C deficiency, unfortunately, is common. Here it's because it included people with type 1 diabetes. Vitamin A and fat-soluble vitamins, zinc, chromium, selenium. So quite prevalent and quite widespread. Now, the risk of premature mortality is not only about obesity, and even less so if obesity is quantitated by the use of body mass index. So the underlying metabolic state is extremely important. So you can be lean and have serious metabolic abnormalities due to the accumulation of visceral adipose tissue or ectopic adipose tissue, and that's the group of individuals who will have the highest mortality of any of the group, because with a variety of illnesses there is some relative protection from obesity, again, particularly if measured by BMI. So that if you're obese and you're metabolically healthy, then you're less likely to have problems than if you're lean and you're metabolically unfit. In addition, if you're obese and metabolically unhealthy and you adopt healthy lifestyles, that will reduce your risk from unfavorable to favorable across the weight categories just by changing lifestyle, even without necessarily changing weight within a category. So you can see that if you don't change any habits, here is the hazard ratios, changing 1 habit, 2 habits, 3 habits, and 4 habits, and the blue being normal weight, the amber is overweight, and the grey is obese. So if you just look at the obese group here, the group with obesity here, you'll see that just 1 habit substantially improves the risk outcome. If I were going to pick 1 habit, I would probably pick resistance activity, but it would be far better to pick 2, which is the elimination of ultra-processed food and resistance activity. Another important consideration is that high body weight variability increases mortality. So here from the Korean Genome Epidemiology Study, which is a 16-year prospective cohort study of 3,600 participants, here you see incident diabetes mellitus as a function of high body weight variability. No difference. Cardiovascular events in this study, no different, but all-cause mortality is increased with high body weight variability. Here is another study adjusting for baseline body weights and looking at the effect of body weight variability and rates of coronary artery and cardiovascular events. So this is 9,509 individuals, and in adjusted models, the quintile with the highest variation compared to the lowest variation in body weight had increased risks of coronary artery disease, 64%, cardiovascular events, 85% higher, and death, 124% higher. I briefly mentioned ultra-processed foods. This is a recent study from an Australian group here in Melbourne, looking at the adverse effects of ultra-processed foods. So the bottom line on this study is that a higher dietary exposure to ultra-processed foods was associated with an increased risk of adverse health consequences in 32 out of 45 pooled analyses. The study design was a meta-analysis of studies, so there were 45 pooled analyses. 12 meta-analyses were included in the pooled, what's it called when you do a meta-analysis of meta-analyses? One of those. And ultra-processed foods was defined by the NOVA classification. So they had a lot of participants to look at. There were over 9 million participants. And here you can see dose-response relationships between greater exposure to ultra-processed food and adverse health outcomes. And they've done this very nicely by looking at grade, looking at the credibility of the study and other quality metrics. So what comes out most consistently is that there's an increase in all-cause mortality, an increase in overweight or obesity, and an increase in type 2 diabetes. There are numerous other adverse outcomes, but with less confidence in those outcomes than the ones I've just enumerated. Here's another study looking at the effect of ultra-processed food consumption and risk of cancer, cardiovascular disease, type 2 diabetes, and cancer. The black mark with the error bars here on the forest plot is without BMI adjustment, and the blue one is with BMI adjustment. And so you can see the significant effects from baseline to cancer, from baseline to cardiovascular disease, from baseline to diabetes, and this is after multiple adjustment. Another important point in a recent publication shows very clearly that the overall dietary quality has a stronger influence on long-term health than ultra-processed food consumption. So if you eat badly all of the time, then your trip to McDonald's is probably more consequential than if you eat well most of the time. So I want to now move to the importance of dietary quality in a weight loss intervention. Now, I must have said this over the last 30 years 1,000 times, maybe more, that less of a nutritionally insufficient diet is not necessarily of benefit even if weight is lost. So here's a study that I did with a visiting fellow from Singapore. We published one in International Journal of Obesity, and this one was in Journal of Sexual Medicine. So these individuals who were men with obesity, but otherwise reasonably healthy, either had a low-calorie diet for 8 weeks or a CSRO diet. The low-calorie diet was about 1,000 calories, so 3 sachets of Optifast and a small meal with salad and vegetables and a small piece of meat or chicken. If they wanted, they could have some fish. Or it was a CSRO diet with the number of calories reduced by about 500 or 600 to induce weight loss. So after 8 weeks, here are the weight differences in the two groups, so almost double it is double the amount of weight lost with a low-calorie diet, almost threefold, 2.5 times decrease in waist circumference. But look at the difference in the plasma CRP. The decrease in the sensitive CRP was only significant with a high-quality nutrient diet, not with a low-calorie diet, even though much more weight was lost. And the same applies for interleukin-6 and SE-selectin, which is a marker of endothelial function. Apart from that issue, however weight is lost, if it involves a restriction of caloric intake, then there's a reduction in lean body mass. This effect is substantially but not entirely mitigated by resistance exercise. And if you optimize protein intake, there's also some degree of amelioration. Now, these are some studies with semaglutide. And what you can see is that as you increase the amount of weight loss, in proportion you increase the amount of lean body mass loss. Here's a study that I did with a group of other Australian investigators and published in Lancet Diabetes and Endocrinology a few years ago. These were a group of men who were enrolled in a testosterone study, but ignore that issue for just a minute. They were also all enrolled in Weight Watchers. So we were comparing testosterone to placebo in men who were attending Weight Watchers or had the opportunity to engage in Weight Watchers for 2 years. Now you can see the change in body weight. The testosterone group is in the red and the placebo group is in the blue. And you can see the amount of weight lost and the reduction in waist circumference. Why did it do that? What I want to draw your attention to is the decrease in muscle mass in the placebo group, as well as the decrease in grip strength that occurred in the placebo group. Now that's ameliorated, in fact reversed, with testosterone, which drives muscle mass and strength in the opposite direction. I'm not advocating testosterone necessarily, but I do want to make the point about the consequences of even a very gentle weight loss program on lean body mass. And we saw much the same with skeletal mass. Okay, so given all of that, is there a dietary pattern that's optimal for health? Because even today, as I flip through the news feed I get, I could have selected from 15 different innovations in diet, many of them which have the characteristics of a cult. I did once name a cultist during a lecture to medical students, and one of the lads at the back put up his hand and provided me with the information that that cultist so named was his father. I wish I could say I'd learned to be more careful. So here is a study comparing a number of dietary patterns that have been shown to have benefit. And in the study, they looked at what's common between these diets. Well, it was limited refined starches, limited added sugars, limited processed foods and certain fats, with an emphasis on whole plant foods with or without lean meat, fish, poultry, seafood. In other words, food not too much, mostly plants. Now, this is not rocket science. It's very easy to teach patients, and I can even manage to teach medical students this. So that the bottom line is that a diet of minimally processed foods close to nature, predominantly plants, is decisively associated with health promotion and disease prevention, and consistent with the salient components of seemingly distinct dietary components. In the Leon Hart study, they called this the Mediterranean diet. Very low in refined carbohydrate and processed foods, low in saturated fat, high in monounsaturates, antioxidants, potassium, fiber, also magnesium, and it had adequate protein. This was not a weight loss study. These were people at high risk of recurrent cardiovascular events. So what they saw was a reduction in LDL cholesterol, increase in HDL cholesterol, decreased triglycerides, inflammation, and a lowering of blood pressure. The cumulative survival without a non-fatal myocardial infarction or major secondary endpoints is shown here. And this intervention was so successful, in other words, all-cause mortality was reduced by 70% early in the trial, that the ethics committee had the trial stopped prematurely to make the results available to the public immediately, and we still debate the matter. This dietary pattern has also been shown in other studies to decrease the risk of dying from cancer, cardiovascular disease, and from developing neurodegenerative conditions. And I would have to say also diabetes prevention and amelioration of the condition. So here is a comparison of 7 popular diets on cardiovascular events in at-risk patients. This is a systematic review and a network meta-analysis. So what they show, just to jump to the bottom line of this, is that the diet that is most decisively associated with the best outcome is the Mediterranean diet. If you can't have that, then for some reason, then a low saturated fat diet will probably do okay. So with that in mind, I've constructed my dietary best bets. And they go like this: avoid processed foods, eat more plant-based foods than animal foods, choose whole grains and legumes over refined grains, eat fish, chicken and eggs and dairy, some red meat, avoid processed meat, drink water, eat in phase with the normal circadian rhythm, and go without eating for 8 to 12 hours a day, in other words, overnight. The elephant in the room here is alcohol. It's a major contributor to weight gain, impedes weight loss, disrupts sleep, increases cancer risk and type 2 diabetes risk, and in contrast to what you may have heard, does not have any cardiovascular disease for any sector of the population or any other benefit other than perhaps fostering some social interaction. Think about that when you're drinking tonight. And then I want to talk about the latest trend, which is chrononutrition and intermittent fasting. So the notion of chrononutrition is this idea, for which there's very good evidence, that if you eat at night, if you have damage to your clock genes for some reason, for example, you create mutations in a mouse or you have some genetic mutation of clock genes, you work at night and sleep during the day, and particularly if you eat at night or you have bright lights on for a large proportion of the night, that you're more likely, or you are likely, to have dysregulated circadian rhythms. And what's known is that this increases the risk of obesity, cardiometabolic diseases, and cancer. So just to take one of these is the issue of sleep restriction. This is a study that I did with Siobhan Banks at the University of South Australia. And what we did was we took healthy young students at the University of South Australia, and we studied them at baseline, and we looked at CGM glucose monitoring, which is this lower figure here. And then over a period of a number of nights, we allowed them to sleep only from 4 a.m. to 8 a.m. And this is what happened to their blood sugars on the final 24-hour period afterwards. So this is very quickly they start developing glucose intolerance. What about intermittent time-restricted eating versus calorie restriction and standard care in adults at risk of type 2 diabetes? This is a study led by my colleague Leonie Heilbron at the University of Adelaide that we published in Nature Medicine late last year. So these people were chosen by their OSD risk score, age 35 to 75. There were 209 of them with an average age of 58. They were predominantly obese. There were 3 groups studied for 6 months with the active intervention and then a 12-month follow-up, and they could continue the intervention during the follow-up, but we didn't provide any ongoing support. So there was our standard control group, a caloric restriction group where they ate 70% of their daily energy requirement, and then an intermittent time restricted eating, which means on one day they ate 30% of their energy requirement between 8 a.m. and midnight and 12 p.m. On 3 consecutive days, and then ate ad lib on the other days. And then we studied them on the morning after a normal eating day, so we could compare the two groups that weren't necessarily having the overnight fast or the fast from midday. So there was no difference in weight, fat mass, or fat-free mass. There was a greater decrease in waist circumference on the intermittent TRE than the caloric restriction group. Now what I'm going to show you here is just the comparison between the intermittent time-restricted eating and the caloric restriction, showing the change in baseline for 6 to 18 months. And what you can see is that there's a metabolic advantage at 6 months that's largely lost by 18 months when they go back to doing whatever they want. Now, my final point is that obesity, penultimate point, is that obesity is a highly heterogeneous condition. Differs in its age of onset, associated abnormalities and presumptive cause. There's a dependence on how you define and measure the excess adipose tissue and what its distribution is, age, sex, and various risk modifications, your muscle mass and function, the level of physical activity, nutritional sufficiency, sleep, stress, and a whole range of other health behaviors, exposures, and social determinants. There are also psychological and environmental factors and the effects of being exposed to stigma. The response to treatment is also heterogeneous, and from the study that I just showed you, here is the metabolic heterogeneity in weight loss in response to the intervention in the ITRE and the caloric restriction group. So the last component of this is the issue of skeletal muscle mass and physical activity. So people with obesity have more muscle mass but poorer muscle quality. Weight loss by decreasing energy intake, including pharmacotherapy and surgery, decreases muscle mass, as I've already shown you. But despite this, weight loss improves global physical function. An adequate intake of high-quality dietary protein reduces the loss of muscle mass but doesn't completely abrogate it. Endurance and resistance exercise help preserve muscle mass during weight loss, but resistance exercise has the greater effect, and both have metabolic benefits independent of weight loss. Resistance type exercise improves muscle strength and lowers glycated hemoglobin independent of fat mass, which is an effect that aerobic exercise does not have to the same extent. A recent systematic review and network meta-analysis indicated that the most effective strategy for nearly all body composition outcomes during energy restriction was by combining that energy restriction with resistance training or mixed exercise and high adequate protein. Now, we need to role model healthy behaviors and promote healthy and supportive environments. This supportive environment is the foyer of the Royal Adelaide Hospital, which you see as you walk in and make your way to my outpatient clinic where I deal with people who have come to get assistance with their diabetes and obesity. People should not have to choose between the environment which is healthy and the unhealthy environment. They shouldn't have to navigate their way through all of the advertising and all of the vending machines and the availability of highly hedonic, energy-dense, nutrient-limited foods that impair health. The healthy choice should be the only choice, and this is the choice that is also most environmentally sustainable. So to conclude, we're dealing with a chronic lifelong condition, whether ameliorated by pharmacotherapy or surgery. Lifestyle measures and attention to psychosocial function are pivotal. We can start off by preventing disease and improving well-being in everybody, whether they're going to get pharmacotherapy or surgery or nothing else. We can identify and manage risk factors and comorbidities. We can proceed to more definitive and long-term and effective treatment strategies that will reduce weight and improve function. But even when that occurs, we have an obligation to maintain health and well-being which requires these strategies, which include personalised management with an integration of nutrition, physical activity, as well as the other modalities with behavioural and psychosocial approaches. A hypocaloric, nutrient-dense diet with adequate protein, appropriately timed, with avoidance of snacking and resistance as well as aerobic activity. Advocacy for a supportive environment and avoidance of stigma are essential elements for long-term outcomes, and good health rather than weight loss should always be the goal. Thank you.
Thank you, Gary. We might ask you to step down now so we can move on to the next speaker. We'll certainly have time for good panel discussion at the end. I want to invite our next speaker, Wendy Brown, up to the platform. Wendy is Professor and Chair of Surgery at Monash University and Program Director of Surgical Services in Alfred Health. I've been told that she's in charge of everything, really, and she's had a substantial role in part of this Congress. Wendy's going to talk about pharmacotherapy and metabolic bariatric surgery, friend or foe. Thank you.
Thank you very much, Louise, and thank you all very much for staying for this last session and also for coming to IFSO. We really loved having you here in our hometown of Melbourne. These are my disclosures. So we all know that metabolic bariatric surgery is a very effective treatment option for people living with obesity. I think some of the best data that really exemplifies this comes from the Swedish obese subject study, which was published now, this particular one in 2012, which shows when compared to a group of obese controls, people with obesity who were their sort of control group, people living with obesity who underwent a range of bariatric procedures achieved and sustained substantial and significant weight loss that was maintained out to 20 years. They've now followed this cohort out to 25 years and beyond. Unfortunately, the group is starting to get a little older because they sort of started this project in the late 80s, and so I'm not sure how much more information we'll get over time. But it's significant and substantial weight loss and translated to excellent health benefits, particularly in terms of reducing the risk of death as well as cardiovascular deaths and events. In Australia, we've been collecting data now for about 12 years through our bariatric surgery registry, and we're seeing very similar outcomes for procedures that are perhaps more modern. So with our one anastomosis gastric bypass, which is the pink line at the top, Roux-en-Y gastric bypass, which is the greener line, the olivey line in the middle, and then the blue line being the sleeve gastrectomy, we see total body weight loss that's maintained out to 4 years of between 28% and 35%. Gastric band has been commonly performed in our country, and we sit around the 20% mark, just under, with gastric banding. So again, significant and substantial weight loss achieved in a nationwide registry, so achievable not just in these expert centres and in large cohort studies, but in the real world, which I think is really important. So we, in the past, have had a range of treatments and still have a range of treatments for people living with obesity who seek them, and they range from diet and exercise alone through to some of the older drugs to the newer GLP-1 agonists, and then we've had surgical treatment and a range again of weight loss that's achieved with the various surgical treatments. Importantly, I think we need to think about what goals we're setting for our patients when we think about a weight loss journey, and over and over again, we've shown that somewhere between 15% total body weight loss and 20% total body weight loss, we start to see real improvement in health. And we can achieve that with all bariatric surgery procedures, but we can now also achieve them, as Priya's just shown us, with the new GLP-1 agonists such as semaglutide and now tirzepatide. So for once, we're now starting to see effective treatments that give people not just weight loss, but weight loss that's significantly going to improve their health. In the Swedish obese subject study, we saw that there was significant improvement in cardiovascular events, cardiovascular deaths, and also total deaths. And the magnitude of that benefit was seen whether or not you had an old vertical banded gastroplasty or if you had a Roux-en-Y gastric bypass. In a study we did here in Melbourne where we followed people very closely with metabolic syndrome, we showed that the threshold for improvement was 15% total body weight loss. We now can achieve that not just with surgery, but also with medication, and I think this is exciting. So because of these new agents that are coming in, and Priya's explained them much better than I can, we are starting to see a decline in metabolic bariatric procedures. Now, whether or not it's because of these drugs being more broadly available and people understanding them more, or if it's because of the economic conditions we're living in, it's undoubted that we're seeing in Australia anyway a real reduction in all of our metabolic procedures. And this is tracking the different procedures according to the years. And you can see in 2024, which is the year here, we're on track for fewer procedures again, as we see, and probably fewer than what we saw in 2018. So there's definitely a downturn in metabolic bariatric procedures. So should I, as a metabolic bariatric surgeon, be afraid of these new anti-obesity medicines? And I guess the question that's been posed to me, are they our friends or our foes? Well, I'd like to advocate up front that I think they're our friends, and I think we should embrace them. And why do I say that? I say that because I think obesity is a complex disease, and trying to hit it with one tool was never going to work. So I think we should be working out how we work together and what we can do to improve the outcomes for all of our patients. How do we help people that have recurrent weight gain, for example? What about people who never get an optimal response? I've shown you some nice means, but in every group there's a standard deviation, and there's always going to be a group of people that get a suboptimal response. What about people living with complex obesity? And what about people that really haven't thought about having treatment for their obesity before? Is this a way that we can start them on a journey? So I think that these treatments give us really intriguing opportunities to use safer operations, potentially to avoid revisional procedures, and maybe a way of starting to introduce the thought of a journey of care that will last that person their lifetime should they choose to embark on it. So if we focus firstly of all on the group that regain weight after metabolic bariatric surgery, I take you again back to that Swedish obese subject study, and I would argue that some weight regain is almost inevitable in any patient who undertakes one of these procedures. Everyone will have a nadir weight, and obviously much greater with something like a Roux-en-Y when compared to a fixed band or a vertical banded gastroplasty. But over time, we've seen in this very carefully followed cohort definite weight regain. Now, they're definitely all doing much better than the group of people living with obesity who did not seek surgery, but there's been weight regain. And whilst out at 20 years, there's no difference between groups on the impact on mortality, there is an impact on other things such as functionality, and there's other reasons why people may wish to seek further weight loss. Because of this inevitability, revisional surgery after metabolic bariatric surgery is becoming more and more common. And in our latest report from the Australian New Zealand Bariatric Surgery Registry, which hopefully you've all got a copy of, 18% of the procedures we reported on were revisional in that year. And that includes needing for conversion, correction, or reversal. So this is something we need to think about, and I think we really need to think about that because it's a thing that's going to continue to happen. And if we just drill down on conversions, when we look at the first 130,000 patients that were enrolled in our registry here in Australia, we had just under 30,000 revisional procedures, many of which were for conversion, and we just zone in on these conversions. It depends on which procedure you've had as to what your risk will be. Out at 5 years, the risk is highest with gastric band, around 12%. And then other procedures, which include SADI and SIPS, because we have small numbers. But you can see that the sleeve gastrectomy, which is 80% of the procedures in our registry, the number looks like it's just about to tip up at 5 years, whereas it's very flat for Roux-en-Y gastric bypass. So this is something we are going to see. It's something we have to plan for. It's something our patients need to know about, and they need to know about that up front. When we do revisional surgery, we do see improved weight loss. When we do convert people from, this is just sleeve to a gastric bypass, we can get extra weight loss, but it comes at a cost. And that cost is the cost of revisional surgery, which is much riskier. These are data from our last report in 2022, but the risk of any adverse event in when you have correctional or revisional surgery is much higher when compared to a primary procedure. and it's highest for the bypass procedures. Moving away from people who have regained weight or need a conversion to another procedure for another reason, such as reflux or diabetes response, there are a subset that never have an optimal response. And this is data we published quite a while ago now, and we can pretty much predict at 3 months if someone's going to have a poor response versus a satisfactory or an exceptional response. So what about, fortunately it's a relatively small cohort, but it's a real cohort, and it's a cohort that I really feel for, because they're a group that have tried everything and then they've finally come to have surgery and they're struggling again. They're not having the response they want. So how do we help them? And I think, do we wait for them to struggle for a year for us to say, well, you're not doing too well? Or do we start thinking early on? We accept they've got resistant disease. They've got a disease that needs more than one treatment. It's akin to having hypertension that needs more than one drug, or a cancer therapy that needs both chemotherapy, immunotherapy, radiotherapy, as well as surgery. So do we look at them a little bit earlier on and say, hey, you're just been blessed with a really efficient metabolism that's really hard for us to turn around, and you might just need to think about some other treatments, and bring them in earlier in their treatment pathway. And I think this is something we do need to think about, because there is this range of how people respond to any treatment, and surgery, like everything, which is this top curve from this lovely paper that was in the Lancet that Priya and Ricardo were part of writing, there is a response. So we need to be thinking about that group that are in that sort of downward trajectory of the normal distribution curve, and think about how potentially in this group we identify them even from the outset and start their therapy before they even get to the point where we have saying, well, maybe you're not going to do as well, your treatment trajectory is not going to be what we would hope for, so let's start early on and just accept it's not just surgery alone that will work for you. And we've been hearing all week that obesity is a lifelong disease, and whatever pathway they choose, it's going to be a long and complex journey for them, because it is really difficult disease to control. If it was easy, we wouldn't be having these complications. But a lot of people don't even want to get on that pathway. In Australia and around the world, we've only ever been able to attract about 1% of people who potentially could qualify for surgery to even think about having the operation. And that can be cost, it can be accessibility. But we have to accept there's a huge number of people that think having their bowel rerouted or having their stomach cut out, it just doesn't sound too attractive. So maybe it is that we can start them to think about, start introducing the idea of obesity being something that really does impact on your health, help them understand that there are treatment options out there. There's diet and exercise, there's psychological therapies, there's all sorts of therapies, but there's also very effective pharmacotherapies. And maybe that's a nice thing to start with and see how you feel when you lose weight. And I think that we'll probably find that many of them after a while think, I really like the way I feel when I lose weight. I like the fact that I'm feeling healthier. I like the fact I can do things with my kids. And maybe it is that down the track I might migrate to surgery. Also, if you're 18 years old, do you really want to start with a bypass? You're going to have a lifelong journey. So we need to think about how we think about an individual and what this lifelong journey means for them. What does the literature tell us about combining therapies? There's really only 2 randomised controlled trials at the moment. We've finished one, we haven't written it up yet, my bad. But this was a lovely study, Gravitas, which came from Alex Miris's group in the UK. It looked at liraglutide 1.8 milligrams, and it was designed for diabetes control after people who'd had metabolic bariatric surgery. And people were randomised to having liraglutide or not, having placebo. And they had 48 patients completed the study that were in the complete case-to-case analysis. And I won't go into too much detail, but it's pretty clear that the group that got liraglutide, who'd already had a bypass and needed some better control of their diabetes, did better than the group that had placebo alone. The Barry Optimised study was designed and came from the group in London with Jessica Mock as the first author. And again, in this group, it was a group of people who'd had metabolic bariatric surgery, who'd had weight recidivism or regain of weight, and they were put on either placebo or liraglutide 3 milligrams. And again, we see there was very effective weight loss out to 24 weeks with the liraglutide arm. But again, there was a response, a difference in response rates, and different people responded differently, like we've seen with everything. So I think we need to think about how we combine therapies, and we need to think about how we combine them sensibly before surgery, at the time of surgery, and after surgery. In terms of metabolic surgery, it might be a nice introduction to surgery, or it might be a reasonable place to start with someone who's never thought about surgery, or for someone who's very young. And from a surgeon's point of view, if we get someone to lose a lot of weight, it may bring people who are very difficult to operate on down to an operable stage. Post-bariatric surgery, it could be useful for recurrent weight gain. But at the time of surgery, we need to think about people we predict are going to have resistant obesity, and think about, do we start it at the time of surgery when they've not achieved the weight loss they wanted, or when we predict that they're at that point. And as I said at the beginning, I think we really have to start thinking about this as a safe starting point and a good way of starting a conversation. Because surgery has only ever been able to penetrate very minorly into the group of people who could potentially have this surgery. And it's exciting now that we have this whole quiver of arrows that we can offer people. And surgery needs to definitely be the target for some people, but maybe we can get to it if we think about how we do things more creatively. So I don't think medications are our foe. I think we need to learn to play nicely together. I hope that we have many, many conferences like this one, and hopefully we never go back to the days where we stand around and argue, my operation's better than your operation, my operation gives this much weight loss. I think we have to put that to bed. All operations provide excellent weight loss. We've learnt from metabolic bariatric surgery that 15% is a reasonable target for most people to look for. And if we can achieve that with medicine, isn't that great? And how do we make sure that we get all these procedures working together well so that we give the best care we can for our most prevalent disease? So thank you all very much.
Thank you, Wendy. A really lovely example of someone who's undertaking cooperative play rather than parallel play. We come to our last speaker before we have the panel discussion. I'm delighted to introduce Ricardo Cohen, who's actually, as of today, the new president for IFSO for 2024 and 2025. He's here also as the director of the Centre for Obesity and Diabetes at the Osvaldo Cruz German Hospital in Sao Paulo in Brazil, and he's speaking on the topic of uptake of obesity treatments. What do patients think? Thank you, Ricardo.
Thank you very much, Luis. Thank you for all being here with us at the last session, and it's a very important partnership between us and WOF. And we heard the wonders of Priya's presentation, the wonders of Wendy's presentations, but how do patients think? This is a problem. And those are my disclosures related to this presentation. And we are operating less than 3%. It's a count worldwide. So we have less than 3% of persons undergoing surgery worldwide. And we have, I'm very optimistic here, around 10% of people undergoing pharmacotherapy. I think it's much less, but I want to be optimistic. And we have here non-responders, this red circle that is around 25 to 30% of people do not responding to either medication or surgery. But what do patients think exactly? This was not performed by us. This is a 2019 expectations of patients in the UK and the US, and most of them, over 50% of them, they thought that self-directed diet and exercise were the treatment of choice for diabetes and obesity. And look at the 5.5% number of the obesity medications here on 2019. Pay attention to this number. This will change over time. And the same for diabetes. Diabetes here, still self-directed diet and exercise is the best option to treat their diseases. And bariatric surgery and obesity medications are down below the line. Because since 2014, metabolic surgery seems too risky. If you undergo surgery, you have a chance to die. But the progress is underway, but it's unsettling. Look at this piece at the New York Times when the children guidelines were released in the US. So some experts that they gave their opinion in the New York Times, they were more terrified to the options of treatment than the disease of obesity. So they were not worried about treating them. They were worried about, oh, they're going to give drugs, they're going to operate people. Wow, what's going on? And then, this is the Guardian, new diabetes drugs do not tackle the root cause of obesity. Experts, I don't know, what are the experts? They say that preventing obesity, avoiding unhealthy food, is better to try to treat obesity. So we have two considerations here. There's a confusion between prevention and treatment because we have already patients with a disease that deserve to be treated. So it's like saying that quit smoking, you're going to avoid lung cancer, and who has lung cancer, well, let it be. Look for your luck. Again, Nestle, in the food business news, look at this. They use stigmatizing language. Obese patients with type 2 diabetes is not stigmatized. They don't call diabetic patients, but they call obese patients. And they say that they can be the right complement to the drugs, to exercise. So drugs are not a treatment. What we need to do is to buy products from Nestle and make people better. What other chronic disease would be talked about in this matter? I don't know one disease that would do this, but there's some progress. The Wired magazine, this is a technology magazine, finally, a new drug switch off my appetite. So it's an article that focuses on the brain's activation after the use of the drugs and its outcomes. And then this group of people here, we founded a non-profit organization. 3 of them are here in the conference, and we call it the Metabolic Health Institute. And we had a research last year, August last year, 1 year from now, in 1,000 patients, 1,017 patients in the US, self-reported BMI over 30. There's drawbacks for this research. Qualtrics was the corporation who conducted the research. And what's interesting is that people say they're more likely to consult a doctor now versus 5 years ago. Well, probably that's because of the new drugs. So they're start thinking about treating themselves of obesity and diabetes. And the drugs, as the Wired article, raised an awareness that there's biology behind obesity. It's not their fault. It's not a psychiatric thing. It's not lack of willpower. It's a disease with biology. But still, most point to behavioral factors as a primary driver of disease, like overeating and sedentary lifestyle. It's over 40% of the responses. So still, people think that it's their fault. And however, regarding medicine, remember the 5.5%, it's twice as high as 2019. So the drugs actually brought something favorable to the treatment of obesity. And what about surgery? Still, when you ask if surgery, what is the most effective treatment for diabetes, surgery stands here at 10%. So, Wendy, we are very bad in communication. Very, very bad. No matter what we show. We have 13 randomized controlled trials with glycemic outcomes where surgery outperformed the medical treatment, but still nobody likes us. And what about the public beliefs about seeking metabolic surgery? So if we compare surgery 2023 versus 2018, 30 were less likely to seek for surgery, and only 22% were more likely to look for surgery. But when we asked to those patients who said they were less likely to consider surgery, still they got back to lifestyle interventions. They say, what is the most important reason you are less likely? They're not the drugs. They go back to lifestyle intervention only. So drugs are friends, and the perception of obesity as a lifestyle is our foe. And again, pharmacotherapy is higher than before. For almost 15% start thinking about pharmacotherapy. But still, 53% still think that it's a lifestyle matter. And when we ask which is the most important reason, when you compare now versus 5 years ago, to consider surgery, again, the biggest reason cited by 35% is they have failed to losing weight with diet and exercise. And 19 of the responders cite reasons linked to weight loss drugs, like inadequate weight loss or consider drugs not as good as surgery. It's a very small percentage. So again, the problem is, the biggest reason is lifestyle and exercise. And if you ask, what is the best course of action in an attempt to lose weight through diet and exercise or weight loss drugs does not produce enough weight loss? What's the response of diet and exercise? Guess. Consider a different type of diet or exercise. So again, we circle back to the same thing, diet and exercise. And drugs? Discontinue drugs and consider diet and exercise. So, Wendy, Priya, we're doing a lousy job. We're not communicating well what we have in our hands. And bariatric surgery is down here after drugs, failing drugs or diet and exercise. What about the beliefs about surgery and other treatments for obesity and type 2 diabetes? Again, which one of the following interventions would be the best for someone like you as a treatment for severe obesity? Well, diet and exercise. So I could put only one slide and we'll be out in 1 minute because it's always the same thing. Which one of the following interventions would be the best for someone like you to treat type 2 diabetes? Again, diet and exercise. So diet and exercise is the champion in all of the questions. This is the way we communicate is not right. And do you agree or disagree with the following statement? Bariatric surgery is too risky. Again, you remember 2014? They thought it was too risky. They still think surgery is too risky, besides its outcomes. And mortality today of bariatric operations is around 0.1%, 0.09% in well-trained centers. So, new obesity management medications are bringing more people to the pathway of care. So they're bringing people to think about treatment. However, most people still believe that diet and exercise are the most effective option to treat severe obesity. And OMMs, obesity management medications, are able to influence the consideration for metabolic surgery. So it's negative and positive. It's friend and foe. I think I agree with Wendy. It's more friendly because we're bringing people to seek for treatment. There will be people who consider surgery because they want a definite strategy, or they have side effects, or they're suboptimal responders. However, given the interest of OMMs to treat obesity, I really believe that there will be an increase in uptake of surgery in the long term. Surgery remains a very unpopular choice for most patients. And the reasons are, first, the effects, the results, and the safety of surgery, they're very underappreciated by many people. And there's a lack of knowledge among the public that surgery is an option and an effective option to treat diabetes. So patients and the public needs to be educated on the evidence-based treatment of obesity and diabetes, regardless of the intervention, surgery or medications. Remember, we're not doing a good job even with medications. And improve communication about the benefits and safety of surgery. This is our job, and this is what I want to do with my one-year term at IFSO, is to promote communication and education to all people involved in the loop of care of those patients. Thank you very much.